This GP cone should be at 25.5 millimeters, and then I'm going to cut this to 35. And then when I place this GP cone to length, I feel for that kind of tug back. I make a crimp with my pair of tweezers. I'll make a measure, and now we're at the correct working length. But when we look palatally, you can see there's like quite a significant ledge. And it's really, really difficult to polish this without damaging the tooth next to it. So what I do in this case... So, hello, welcome to this week's Friday clinical case. And this is a case of trauma. And I, granted, hadn't seen this tooth immediately after the trauma. And this was an external referral from a very good colleague of mine regarding the two upper central teeth. And this young man was on holiday and fell on a water slide and broke his front teeth, and mum and dad were absolutely devastated about the situation. They would just wish they'd never been on holiday, etc, etc, etc. But from a clinical point of view, this case has got a number of things. One of them is case selection and knowing when to refer and when not to refer. This is another case about apically gauging as well, and knowing which sort of obturation technique to go for. Should you go for a more conventional obturation technique, or should we go for more like a kind of a apexification with an apical plug? So there's a lot to talk about today. But before we get on with the case, again, like I always say, we look at the metrics of the channel. 50% of the people who watch these videos regularly aren't subscribers. So if I could ask you to just do one thing, it's quick, it's easy, and it's free. Just hit that subscribe button and also the notification button. If you hit the notification button, what you'll get is notifications of new uploads, and also pushes the channel, supports the channel. And if you want to support the channel even further, we've got a membership program. The membership program, you get early access to content. So if you like this video, you can watch scheduled videos up to 4 weeks ahead. And also we've got exclusive content. We've got a fantastic endodontic access video just for members only. The general public can't see them. And also we've got our part 2 for our newly qualified dentist survival guide. So we'll look into the case. So like I said before, this is a case of an upper right one and an upper left one. So the two central incisors, they were knocked on holiday. And in fact, when we look back at the case notes of this, the referring dentist had done a really, really stellar job on managing these types of cases. So initially, the teeth weren't deemed necrotic. The pulp the referring dentist essentially was just reviewing these teeth, but it transpired, of course, that especially the upper right one there was suffering from external inflammatory root resorption, which was quite significant. And in fact, this is one of the reasons why the referring dentist had referred to us, because she understood that this was going to be a challenge to obturate. And essentially, when I'm looking at these types of cases, this is what's going on in the back of my mind. I'm thinking about how is this tooth going to be obturated, especially the upper right one, and especially with regard to consent. We spoke to the dad extensively about this tooth and about the difficulty in sealing these teeth up, and obviously how that has effect on the prognosis. But nevertheless, he's a young man. Tooth needs to be treated, and of course we've treated it quite successfully. But in the back of your mind, when you're thinking about these types of cases, you've got to be thinking about what you're going to be doing and how that might impact the patient later on. So we'll get on with the case. We'll go to the video. In these types of cases, I do like to multi-isolate the tooth. So what I do is, when I do multi-isolate anterior teeth, I go from the 4 to the 4, or the premolar to the premolar. Sometimes I like to go from the canine to canine, but in these cases, premolar to premolar is better. I'm just going to check we've got the correct rubber dam clamps, because premolar size, is just a wide variance. And then when we do multi-isolation, in this case, I don't place the rubber dam clamp onto the rubber dam sheet. I get my nurse to help here, so I I push the rubber dam clamp onto the teeth on the left-hand side. She passes me the floss, and then I get my rubber dam clamp and I clamp it onto the premolar. And then sometimes I do a little bit of flossing just to get through the contacts, or I just, in this case, I go on the right-hand side, place the rubber dam clamp, get the nurse to retract the rubber dam as I place the rubber dam clamp on, and then just floss the contacts and make it all looking nice. And I noticed here that the frame was slightly off center and the patient was biting onto the frame, and also it was covering his nose. So I just want to just sort of fold the rubber dam sheet back and then just re-center the rubber dam frame, because this is the patient's gonna have to sit here for about an hour and a half to 2 hours. So we want to make sure that the frame isn't digging into his chin like it was here. So first things first, we're going to remove the temp fills. The patient's normal dentist had been reviewing these teeth, and then when it found that the teeth were necrotic, she's dressed it with non-setum calcium hydroxide and also PTFE tape. So she knows what she's doing. And removing PTFE is pretty straightforward compared to cotton wool, but it can be a little bit difficult, especially if you haven't removed all of the temporary filling material. But once we've removed the PTFE, I'm just going to give it a good old clean up with the high energy ultrasonic. And what I do notice is that these access cavities are quite narrow, and if I'm going to be doing an apexification, if I'm going to be using warm vertical compaction, I'm going to make sure I can see the root canal proper, so I can have lots of visualizations so I can do the obturation correctly. And I'm using these low energy ultrasonic diamond tips, but it's taking a bit of time. What I do is I just pick up my fast handpiece and just make sure I give it a little bit extra, essentially just to open up the access cavity a little bit. You've got to be careful, of course. You don't want to remove too much tooth tissue. Also, you've got to be really, really mindful of the tip of this fast handpiece, and you don't want to be touching the buccal wall. And what I noticed is I don't really know where I am with this fast handpiece, so I'm just going to get this blunt-ended this endo-Z burr just to make sure that I'm not removing excess tooth tissue. And we've opened up the canal orifices quite significantly, and we're just going to make sure we do a bit more irrigation. But I feel like the palatal shelf, especially on this upper left one, is still quite significant. There's a little bit of a ledge there. Remember, to obturate these really, really wide canals, you need vision. That's just my opinion. People might think that this is excess tooth tissue removal, but the amount of times, I've tried to obturate a tooth where it's been a really, really narrow prep and there's been void, it's been a bit of a nightmare. So in my opinion, I feel like a removal of a little bit more tooth tissue, I'm not saying excessive removal, but a little bit more to make sure you get that nice solid 3D fill, in my opinion, is a good kind of compromise, shall we say. And also, by using the ultrasonics, you've got to be very, very mindful of our heat, because using these without water can sometimes cause to fracture. But you can see here now we've got a nice open wide access cavity, so we can have a bit of vision when we do our obturation. And then just make sure we get those pulp horns as well. And what I noticed here is that the rubber dam isn't quite sealing off all of the tissues, and in fact there's a significant amount of gingival tissues exposed here, and the patient will be fine, but what you don't want to be getting sodium hypochlorite into these tissues, because it'll bleed like mad. The patient will be sore. So I'm just going to use a little bit of liquidam here, and this liquidam is light curable. So I'm just going to cover these gingival tissues here, and then I'm going to set it with a light cure, and that's going to protect the tissues really, really nicely. The upper left one's completed, and now I'm just going to adjust the palatal shelf for the upper right one. Luckily in this case, it's not as a narrow access as the other central, so it doesn't take me too much time to adjust the upper right one palatal shelf in this case. And then once we open everything up, we're ready to take our working length check. And when I place this size 10K file into the canal, I get that kind of like little bit of a sticking sensation, but if I give it a little bit of twirl around, it sort of pushes past. And in my mind now, I'm thinking to myself, what's going on there? Because I thought this was a wide open apex, and there might be a bit of unusual anatomy, or there might be a little bit of a calcification bridge occurring here. So what I do is I take a working length radiograph, and we get past this point. We adjust the stopper, and now we've got a 0 reading. We know we've got the working length on this tooth, and I think in this case it'd be more predictable for me to create a known apical diameter rather than keep that calcification bridge. Again, people might disagree, and the 0 reading on this upper right one is 22.5 millimeters. We're then ready to do our working length in our upper left one, and again, on the X-ray, it doesn't really look like it's a huge open apex, but when I'm trying to get this working length, I notice that the size 25 length hand file isn't long enough, so I pick up a size 31 K file. This gives me a little bit more file for me to maneuver around and grip onto it, and we find out the working length of this upper left one is 26 millimeters, so it's a significant amount of length here. And also, don't forget as well, the upper right one is lost a significant amount of length to it, because that one was 22 and this one's now 26, so it's lost quite a lot of tooth tissue. I'm going to go straight for the working length check in the upper right one, and what I'm going to do here is I'm going to do something a little bit different. I'm going to place the GP cone up to the point where I felt the ledge, and then I'm going to place a hand file past or up to the point where we found 0, because a lot of these times when you get these very, very large open apexes, is that the apex locator doesn't really work very well. So what I want to check is the point where the ledge is at the end of the tooth, or where the hand file is. And unluckily for me in this case, I forgot to repress record, so the video goes into the point where we've got both instruments in place, or the GP cone and the instrument in place. And then also you'll notice is, because I'm doing a cone fit radiograph for the upper right one, I might as well do one for the upper left one as well, just to make sure I'm in the correct vicinity. I'm not apically gauging in this situation. I'm just loosely placing the GP cone to the 26 millimeter mark, just to see if I'm in the vicinity, because I'm also worried about the apical diameter in the upper left one as well. And this is the great thing about multi-isolation now. As you can see, if I'd placed rubber dam clamps over these two teeth, or one of these teeth, it'd be really, really difficult for me to get the X-ray beam perpendicular to the film. And when we take this working length check, we can see that the upper left one's to length, and in fact the hand file, the one that got 0 on our apex locator, is at the correct length, not the GP cone. So that's kind of we're worried about accuracy, so that's just a working length confirmation. I don't often do that, but I just like to sometimes, if I'm not too sure. And despite the upper right one having an open apex on the radiograph, I am going to shape this canal, and I'm going to start with a glide path file. And to get past this kind of ledge, or this dentine bridge, or this calcification bridge, I'm just going to manually place the glide path file to length. I'm just going to make sure I'm going to get a bit of a shape up. And then essentially what I do is I am creating an apical diameter with this tooth. So I'm going to use a size 25 high flex. Again, this kind of sticks on this little ledge bit here, but once we get it past, I'm going to shape that to 25, and then I'm going to use WaveOne Gold 35. And I could stop at this point, but I feel like that I think that probably the end of the tooth is a bit unusually shaped, so I just want to make sure that I'm not going to stop on 35. I'm going to make sure that I'm going to stop on 45 to make sure I've got that sort of definitive apical diameter. And then I'm going to start the apical gauging process in the upper right one. So I'm going to get a matched cone. This is a WaveOne Gold 45, and as I push this down into the canal, you can see that I'm way past. I'm at 24.5 millimeters, even though the working length is 22.5 millimeters. I'm going to cut this GP cone to 65, and then as I push this to length, I feel, well, I'm not too sure what it is at this point, but I can't quite grip it because it's quite far down in the canal. So what I'm going to do is I'm going to make a little mark in the GP cone here, and then I'm going to pull this out, and then when I measure where the mark is on this tip of this GP cone and I measure it to see how far it is, it's at 22 millimeters. So I could muck around creating GP cones and making them longer and things like that, but I'm happy that this is at the correct length. So I'm going to push this GP cone to length, make sure it's really it's snugly at length, and it's also at that mark, and then I'm going to leave that in place ready to do our cone fit in a moment. And I'm going to start to apically gauge the upper left one, and then I am going to cut this at the moment that's 30 because I'm not too sure what the approximate length is. We're going to measure it to 26, and then when we fit this to length, I feel for a little bit of tug back, but this pushes past the mark that I've made at the correct working length. So this is measuring to 26, and of course it should be this GP cone should be at 25.5 millimeters, and then I'm going to cut this to 35, and then when I place this GP cone to length, I feel for that kind of tug back. I make a crimp with my pair of tweezers. I'll make a measure, and now we're at the correct working length, which is 25.5 millimeters. It's a little bit concertina at the end, but I'm happy that that's a good cone fit. That's going to give me a good cone fit. And then when we take another periapical radiograph, we can see that the upper left one cone is to length, and the upper right one, yeah, it's not too bad. It's not too bad. Maybe there's a little bit more space. So at this point, I'm thinking to myself, do we obturate at this point? We've got a bit more time. It's kind of a bit of a way up, isn't it, between taking loads of x-rays on a patient and getting a good seal. But in this case, I think to myself, it's worth a shot at seeing if this GP cone will fit snugly at length at 60. So what I do is I get a fresh GP cone, I cut this at 60, and then what I do is I fit this to length in the upper right one. I feel for that kind of tug back, I pull it out, I measure it, and I can confirm that it's sitting at about 22 millimeters, so we know that that's around about the working length. Again, I push this to length, and then when we take the second cone fit radiograph, we can see that this now cone is way past the working length. So I'm not happy with this, and I think because I can't go in between 60 and 65, I'm going to go for this 60 instead. But whilst the X-ray is developing, I'm just going to set up the tray table. So I'm going to give everything a clean up. This is me getting ready for the obturation process. We're going to get a fresh paper towel. We're going to get my GP disinfecting ring, make sure all the little irrigants are all in the right correct wells, and then I'm just going to remove the upper left GP cone, because we know that's the correct GP cone, and I'm going to place that into the well. Notice there's another GP cone there. That's the previous one, the one that's cut to 65, and then this is the one where it's a bit too long, so I'm just going to discard that to the side. So we're going to do our final irrigation protocol. This is going to be sodium hypochlorite 5% activated, EDTA 17% activated, and then sodium hypochlorite activated. I'm going to make sure everything runs clear as we activate, and we know that's when we're ready to finish. We're then going to obviously dry with paper cones. You've got to be careful because these apexes are quite wide, so you don't want to push the paper cone through. And you'll notice here there's a bit of blood here, but I think that is controlled, and I think that's just where the paper point's been pushed through. And in fact, if you measured that, it'd probably be at the correct working length. So just be mindful, because if you push a GP cone through and you touch tissues, you can tear the tissue and it can start to bleed. So it's a bit of a nightmare. We're then going to prepare our cones for obturation. I'm going to start with the upper right one. I'm going to dip this in isopropyl alcohol. We're going to give this a little bit of a dry, so this is all nice and dry. All the residue from the sodium hypochlorite is off this GP cone. And then I'm going to obviously dip the disinfected hand file in isopropyl alcohol, give that a little bit of a dry, put that to one side, and then we're ready to do our obturation with our sealer. I'm going to measure the tip because I'm worried about the size of the apex, and then I'm going to backfill this directly into the canal. Again, you see in a lot of my videos, I can do this because I've got direct vision with a microscope. And then I know this is a really, really wide canal, so I'm just going to make sure I'm using loads and loads and loads and loads of sealer. And then once we've backfilled the coronal to mid-third of the tooth with the sealer, we're going to get a hand file. We're going to use that hand file to introduce into the canal, so you get rid of that kind of that vapor lock, so the GP cone fits the length nicely, and also it introduces the sealer into the apex. And you'll notice here that I'm pushing this GP cone really, really nicely to length. I'm going to feel for that snugness that it's fitting at the apical end, and then I'm going to remove a little bit of excess. And what I do notice with these centrals is I think this is quite wide, and this GP cone doesn't sort of fill the vast majority of this canal in the coronal third. And if I try and condense this down now, it's probably going to the Mach 2 plug is going to slip past it and cause a bit of a nightmare. So I'm going to use an accessory cone. Don't forget, these need to be disinfected. I'm going to use an accessory cone here. This makes sure we've got this really nice big 3D fill. I'm going to push it to length, remove the excess here, easier said than done. And don't forget as well, we need to make sure the GP sits below the level of the CJ, especially in anterior teeth, because obviously the teeth can discolour. And then I'm just going to use a Mach 2 plug here just to push it down. And I know that I've apically gauged this, so I know I don't need to worry about pushing this down really down to length. And what I do is I push it really hard down, clean the excess sealer, and then tidy it up a little bit. And it's the same protocol with the upper left one. Problem here again, I don't know what happened with this case. I just kept forgetting to press the record button. But again, it's the same sort of protocol with the upper left one. And we can see here now that both these teeth are obturated. And now it's just a case of me just removing excess GP so it sits below the level of the CJ. What you'll also notice as well, if you've got an excess amount of GP, it's difficult for you then to condense it down. So it kind of mushrooms over the sort of access cavity, and it stops you from condensing it successfully. So that's another reason why we like to remove a lot of the excess tissue. It's quite fiddly to do as well. A lot of the times what you can do is that you are using the heated plugger here to remove some excess, and then sometimes inadvertently, because there's not a lot of vision, you can pick the cone up as well and pull the cone out. That's really, really annoying. And then there's a kind of a case of then do you start from the beginning, or do you just put the cone back to length? A lot of the times I'm happy if I haven't pulled it all the way out, because I can see with the microscope I've pulled it a little bit out, just push it back in, and I would say almost all of the times this looks fantastic. And this is another reason now. What you'll see is that before I fill this tooth with its definitive restoration, if I fill the access cavity up, I will take an x-ray just in case I need to make any kind of adjustments. And then when we look at the x-ray, perfect. There's a massive, massive, massive way up here, isn't there? Because, I've obturated this quite nicely. The upper right one I'm talking about, upper left two looks pretty good as well. But, there's a case here to do this apexification. And in fact, halfway through the appointment, while we were waiting for, I'd cleaned up and things like that, but we were still waiting for the x-ray to go through, I spoke to the dad. I said, there was a bit of a way up, isn't there? Because on the one hand, we can fill it conventionally, and then, it might not get that 3D fill you would with this kind of plug. And I explained what it all was. I said, on the other hand, we can complicate things. We can try and do the plug. And obviously, if you complicate things, and more things can go wrong. And I said, between 60 and 80 is the kind of cut-off for most dentists who are doing an apexification. Of course, if you've got an open apex and it is more than 80, then that definitely needs an apexification. But in this case, I feel like, you know, the end of the tooth was circular-ish, you know, it was like irregular shaped. So I'm relatively happy that I can get a solid filling here. And don't forget also is I've created the apical end using my my hand files. And then, you know, the next challenge here, and probably the biggest challenge, is now to place the definitive restoration. So in the first instance, I'm just going to fill the access cavity up completely. I'm using this self-etched bond, but obviously the access cavity is very, very narrow, so I'm going to use these paper points just to wick out any excess bond. And then I'm going to use this smart dentin replacement just to fill the access cavities up. A lot of the times this causes like a bit of a bubble, so sometimes I'll get a little probe in there just to get rid of the bubble, and then we just fill it all the way up. And then I'm just going to finish off the polishing up of this access cavity, or access cavities in both these teeth. And then the next challenge, of course, is to replace the filling here on the upper left one. And because it's slightly imbricated, it's slightly crooked, it's really difficult to get that kind of margin against the palatal on this upper left one. So it's really, really frustrating. You can see here that I'm really finding it difficult to place this this clear strip. But in this case, I managed to get it on, give it a bit of a wash, bit of an etch. And then I'm kind of looking around here to see how I can form the palatal of this final restoration. And sometimes your finger works really well, and you'll have to excuse me because, again, I'll say it once, say it 1,000 times, I'm not a restorative dentist. I'm sure there's a much better way of this, but this is just me. This is how I do it. And I'm thinking about maybe using you know, the back of my instrument or whatever, but in this case I'm just using some eye bond, and I'm going to use a tiny little bit of flow here. And you'll notice that I'm just putting the composite in here, and it looks really rough. You'll also notice is the colour match difference, and this will get better because don't forget the patients had rubber dam on for about 2 hours, so that all the teeth are dehydrated, so it makes them look a lot whiter. And you can see that now. I've given a bit of a polish up. I've formed the buccal surface of this. It looks pretty good. I'm going to polish that in a moment, but when we look palatally, you can see there's like quite a significant ledge, and it's really difficult to polish this without damaging the tooth next to it. So what I do in this case is I don't often use these, but they're in my top drawer, and I'm using the finishing strip. So I use these very judiciously. I don't like to use these too much, but I give it a good old polish with a white stone. Everything looks really nice. And when we look at the tooth here, it looks much better, and the dad has been told that because of the imbrication here, because of the crookedness of the teeth, it's really difficult for us to place a really solid restoration. So what's likely going to happen is that they're going to go see their orthodontist, the teeth are going to be straightened, and then what we're going to do is it's possible you just might need to polish it up, or you know, we replace the filling, and overall it's a nice result. Thank you very much for watching. If you got any questions or criticisms, place them in the comment section below. We like criticisms, okay? We get a lot of harsh criticism on the comment section below, but it's great because it makes people think, it questions our practice, and it makes us better dentists, doesn't it? And you know, if you haven't subscribed, please subscribe, and of course we've got that membership program, and I'll see you in the next video next week. Bye bye.